Okay, so we are live. I had gotten some calls, so I had to end the stream. And I'm done with the calls now. So I'll just teach for some time. And I think I have to teach until I'm done. Until here, and I'll come back after a few minutes. Give me some time. Deep tendon reflexes, jaw jerk, biceps, brachioradialis, supinator, radial periosteal, triceps you have, knee jerk, quadriceps, patellar reflex, ankle jerk, clonus if it is present or absent, patellar or ankle, latent reflexes, which is suggestive of pyramidal tract lesions if it is present unilaterally. Tromner's reflex like finger reflex or Hoffman's reflex, and Wartenberg's sign you can check. So grading of deep tendon reflexes are there. You have 0 is no sign, 1 is slight but definitely positive response, 2 is brisk response, 3 is a very brisk response, and 4 is severe clonus. Tap itself, tapping elicits a clonus. Always abnormal, 3 is always abnormal. Brisk response is normal, very brisk may or may not be normal. Then primitive reflexes, you have glabellar, tap, palmomental, both sides tapping, sucking, rooting, pout, snout, and grasp reflexes. All of them you can check in babies. Involuntary movements which you can describe, and coordination which is later described under cerebellum. Sensory examination, you can test for touch, pain, temperature, vibration, joint sense, and at any sensory level and pattern of sensory loss, like graded, dissociative, or crossed and hemi. Cortical sensation is tested only in the presence of a primary sensation intact. It is tactile localization, 2-point discrimination, stereognosis, graphesthesia, and sensory extinction. You can also perform the Romberg's test. Cerebellar signs, you have limb ataxia, which is outstretched arm test, finger nose test, and nose finger nose test, and finger finger test. Rapid alternative movements, you have rapid hand tapping, pronation, supination, and thigh slapping. Pointing and past pointing will be there, and writing, you have macrographia. Rebound phenomenon may be there in the arm, and tremors, intentional tremors may also be there. Lower limb, you have knee to heel test, pendular knee test, finger toe test, and rapid alternative movements, foot tapping can be seen. In general examination, you have titubation, nystagmus, tremors, hypotonia, truncal ataxia, wandering gait, and tandem wandering and gait. All of them you have to check. This is cerebellar. So going back to gait may be, the base may be wide or narrow, it may be slow or rapid gait, there may be falling to sides. You have to look for which part of the foot touches the ground first, whether it is the heel or the toe. How high hand swinging, if they are turning around, how they are turning around, position of the hip, sound production when the foot touches the ground, all of them should be checked. Signs of involvement of autonomic nervous system, drainage, postural hypotension, baseline heart rate, palpable bladder, and papillary reaction with Valsalva maneuver, all of them can be checked. Signs of meningeal irritation, you have neck stiffness, Kernig sign, or Brudzinski's sign. Skull and spine, you have deformities, tenderness, and short neck. Soft neurological signs, you have pyramidal drift, cerebellar drift, and parietal drift. Pyramidal drift is hand to move upward and supinate. and if the hands are held outstretched in a pronated position, or pronate downward if the hands are held in supination. Cerebellar drift is an upward with excessive rebound movements if hand is suddenly displaced downward by the examination. Uh, so yeah, the hand, if there it is pointing upward, it will point downward. Pronation will occur if it is supinated. Supination will occur if it is pronated. Cerebellar is upward with excessive rebound movements if the hand is suddenly displaced downward. Rebound movements will be there in cerebellar. Parietal drift is outward movement on displaying ulnar border of supinated hand. So ulnar border is displaced and you can see outward movement. Respiratory system you can find inspection, palpation, percussion, auscultation. Cardiovascular system inspection, all of them you can do, and GA also the same things. So diagnosis, you most commonly need to do for cerebrovascular accident. Most common cases which you get is cerebrovascular accident, and the diagnosis should be exactly like this: sudden onset, which side, then hemiplegia with upper motor or lower motor palsy due to cerebrovascular accident. Possible embolic or thrombotic or hemorrhagic etiology. Site of lesion being left internal capsule or possible sites you have to write, involving lenticulostriate branch of middle cerebral artery. Possible involvement, and the patient is in a state of neuronal shock following risk factors. Okay, if they're in a state in neuronal shock you have to write, and risk factors you have to write. And for cases of neuropathy, acute onset, symmetrical flaccid quadriplegia, no evidence of sensory or bowel or bladder involvement, and with bilateral lower motor nerve facial palsy. Possible site is peripheral nerve. Demyelination, acute inflammation, demyelinating polyneuropathy. Spinal cord diseases, you have symmetrical spastic paraplegia, sensory bladder or bowel, no involvement of cranial nerves, vertebral tenderness at T45, spinal cord. Horizontal level may be there, vertical level also you have to examine. Above T4, T8, all of them can be seen. Probably TB, port scan. Extrapyramidal Parkinson's disease, you have insidious onset, slowly progressive, degenerative disease involving the motor system. No evidence of sensory, cranial nerve, bowel, bladder involvement. Extrapyramidal, probably Parkinsonism with no evidence of secondary causes, or Parkinson's plus. It can be staging also you have to write. For ataxia, slow progressive insidious onset, slow progressive medical ataxia, cerebellar signs. So cerebellar signs you have to write. No evidence of sensory, cranial nerve or autonomic involvement. Degenerative cerebellar ataxia, possibly inherited, family history is positive. So it can be, you have to write about onset and deficit, and then you have to write about the site or involvement of neural association. So we will discuss in detail after a little while. Give my voice a little bit of a break and I'll come back.